Good morning, respected Chairman Sir, VC Sir, and all the dignitaries and students. On behalf of the Department of Psychiatry, Mahatma Gandhi Medical College and Hospital, Jaipur, I welcome you all to the session of CCR held on 9th July 2025. Today's presentation is the result of collaborative efforts of our postgraduate residents and psychology trainees under the supervision of our faculty. Our department was established in 2001 as a teaching unit, and since then we have come a long way. We have started offering MD Psychiatry in 2010 with just one postgraduate seat, which increased to two in 2013. With the growing academic strength and clinical exposure, the intake was further increased to four MD seats in 2021. The department is supported by dedicated and experienced faculty team, which includes Dr. Manju Bhaskar ma'am, who is our professor and HOD, myself, Dr. Aditya Soni, Dr. N.K. Tak, who is associate professor, Dr. Gitika Chopra, Dr. Srishti Sharma, and Dr. Priyam Gupta, who are assistant professors. Our department offers a comprehensive range of psychiatric services both at outpatient and inpatient levels. We have integrated neuromodulation into the routine care, which includes RTMS and modified ECT, along with evidence-based psychological interventions like MBT, multi-behavioral therapy, and biofeedback therapy. In addition to routine services, we run specialty clinics in 6 days in a week, which we have mentioned over here. As a department, we strongly believe in extending our services beyond the hospital walls to ensure community engagement and mental health awareness. Key outreach includes activities which include OPD at Vatika PHC, student counseling cell, community awareness programs, tobacco cessation services, TCC, and soft skill workshops. These initiatives reflect our commitment to preventive psychiatry, community awareness, and capacity building. Most recently, we have hosted the second Raj Med Psychon 2025 on 24th and 25th May at the Palace, Jaipur, with the theme of Shifting Paradigm, Gender Sensitive Psychiatry. It was a good conference with greater than 200 faculty members who attended the conferences from all over the Rajasthan. These are the students who have received awards and in the following categories, like Jaipur Award, Best Poster Award, from by Dr. Gaurav Purohit, Dr. Navya, who received first prize in paper presentation in MedSips, also first prize in poster presentation. Dr. Aryan, who recently received first prize in paper presentation. And our alumni, who is Dr. Prerak, is currently DM in geriatric psychiatry. Dr. Nishant is working in AIMS Batinda, and Dr. Aprajita in senior resident IBHAS, New Delhi. Dr. Kuldeep, MRCP UK. Total, we have 82 projects, out of which 67 projects have been completed and 15 are ongoing research projects. Total publications on Scopus and PubMed is 42, with a total citation of 250. With that, I would like to invite our postgraduate student, Dr. Aryan, to begin today's CCR. Thank you.
Good morning, respected dignitaries, my esteemed faculty, and my dear colleagues. We welcome you all to today's combined clinical rounds presented by the Department of Psychiatry at Mahatma Gandhi Medical College and Hospital. I, Dr. Aryan Kotia, am going to present a case of a 20-year-old female presenting with multiple episodes of self-harm. This case of a 20-year-old unmarried female currently pursuing her post-grad in MCOM second year. She is a resident of Jaipur, Rajasthan, and she was brought to the OPD by her eldest sister, who has been closely involved in her care and was also the primary informant during the history taking. She presented to our OPD with chief complaints of suicidal ideation, verbalized as मैं जीना नहीं चाहती, मैं सब कुछ खराब कर देती हूँ, कोई भी मेरे साथ नहीं रहता, since 4 hours, inconsolable crying since 2 hours, nausea, sudden palpitations, body tremors, profuse sweatings, and feeling of impending doom since the last 30 minutes. The mode of onset for psychiatric complaints is abrupt, with a total duration of illness of 2 years. The current episode is of 4 hours. The patient presented to OPD late afternoon in a state of acute emotional distress, crying uncontrollably, hyperventilating, clutching her chest, and complaining of nausea with a racing heartbeat since the last 10 to 15 minutes. She appeared overwhelmed and we were unable to soothe her. Repeated suicidal thoughts with a recent self-harm using a safety pin. Superficial injuries visible on the forearm. This particular episode was triggered by a confrontation with a roommate and her partner, whom she accused of betrayal, which led to the emotional flooding and impulsive actions. She voiced a persistent inner void that nothing makes sense. I don't know even who I am. She often accused of others of wanting to harm her, showed inner emptiness, and acted impulsively when distressed. And on presentation, she was tearful, emotionally labile, and she was easily overwhelmed. On presentation, the patient had stable vitals but a raised pulse of 112 beats per minute. She was subsequently admitted to the female psychiatry ward for detailed evaluation and further management. She was counseled, and to address her acute anxiety and distress, she was given a tablet clonazepam 0.5 per oral stat in the OPD. Over the last 1 to 2 years, the patient has had multiple similar episodes of acute distress. Each episode was marked by sudden emotional breakdowns, physical symptoms like palpitations, nausea, and breathlessness, along with inconsolable crying. These episodes were frequently triggered by interpersonal conflicts, often with friends, partners, and family members. And she had visited multiple hospital departments before coming to us, including emergency medicine and even surgery. But the approach was largely symptomatic and fragmented. Despite repeated expression of suicidal ideation, there was never a comprehensive or structured psychiatric evaluation. There was never a constructed or a structured psychiatric evaluation done. This slide highlights one of the key emergency visits where the patient presented past. In this particular episode, she presented to the emergency with suicidal ideations and panic-like symptoms, including tachycardia, hyperventilation, and sweaty palms. Despite a normal workup, she was diagnosed with panic attack and discharged with advice for just stress management. In this second slide, the patient presented to the surgery OPD with wrist bleeding. She reported it as an accident with glass, and the wounds were superficial. All investigations came back again normally. The clinician did suspect self-harm but did not act on it. No suicidal risk assessment was performed, and there was no psychiatry referral. In this third visit, the patient presented to the general medicine OPD with vague somatic symptoms like fatigue, headaches, disturbed sleep with loss of appetite. Again, all investigations were normal. She was diagnosed with stress-induced somatization and was managed symptomatically with vitamins and a proton pump inhibitor. However, underlying mood symptoms like low mood, sleep disturbances were not addressed. This again emphasizes the tendency to label symptoms as stress without exploring deeper psychiatric origins. In her only previous psychiatry OPD contact, the patient presented with low mood and fatigue. While suicidal thoughts and emotional instability were mentioned, they weren't explored in depth. She was diagnosed with depression and started on pharmacotherapy after all the routine investigations. However, she took the medications irregularly for 4 months, and then the patient formed a strong emotional attachment, leading to a therapeutic deadlock. Eventually, she dropped out of the treatment, no psychotherapy was offered, and her underlying personality features and panic symptoms were missed. There were no prior psychiatric admissions, and medically the patient had no significant past history. Family history of the patient. The patient is the fourth of the 5 siblings. She has 3 elder sisters and 1 younger sister. Father has a history of chronic alcohol use, often associated with verbal abuse and domestic conflicts. The patient's mother passed away during her childhood due to a chronic medical condition, and she was subsequently raised by her stepmother. Frequent interpersonal disputes between parents throughout the patient's childhood were common, and hence the home atmosphere was often described as chaotic and emotional, and there were no diagnosed psychiatric illnesses in the family. Eliciting personal history in psychiatry is not just a formality. It's a vital part of the assessment. This process is often carried out over multiple days by the same treating doctor. Why? Because it requires building a strong therapeutic rapport. Many aspects of the patient's personal life, including sensitive experiences, might not be openly shared with just anyone. And here, the patient's birth history showed no significant abnormalities, no antenatal postnatal complications were reported, and the developmental milestones were also at par with the siblings. The patient grew up in a chaotic household with frequent parental conflicts, often leading to emotional volatility. Patient also exhibited early emotional sensitivity, frequent temper tantrums, and had difficulty forming stable relationships. And hence, also the parenting style described at her home was described as inconsistent, at times critical. There was frequent emotional neglect reported, and the patient often felt unheard and invalidated, especially when the patient had her sister pleaded their father to quit alcohol. The patient's academic history reflects emotional instability since the early on. The patient changed streams in 11th due to peer pressure, but she completed her 12th from an English medium school with average result. Currently, she is enrolled in the MCOM, but her attendance is still irregular. The patient started consuming alcohol whenever she is under stress. No signs of dependence or withdrawal. This qualifies as harmful use given the psychological and the functional impairment it contributes to. Cannabis use is also reported to be occasional and limited to episodes of emotional distress. There is no history of IV drug abuse or sustained substance dependence. The patient attained menarche at 13. She had multiple romantic and sexual relationships that were typically intense and ended in conflict. Although she comes from a financially stable family, she showed strong motivation for independence. She worked as a primary school teacher but was unable to sustain jobs due to frequent difficulties at work. So now this slide gives us the snapshot of the patient's personality before the onset of a current illness. She always been described as emotionally intense and very sensitive. In her early years, she came across as outgoing and expressive, but this would often shift quickly to frequent mood swings. She has had a tendency to form quick and intense attachments, and she also showed high reactivity to criticism, which often lead to distress or impulsive action. Finally, her decision making was often impulsive. This slide continues the picture of her personality. She would easily get irritable or overwhelmed even by minor stressor. Emotionally, she often felt empty or invisible and would often crave attention or reassurance. This pattern led peers to see her as overly dramatic or emotional, especially during arguments or stressful moments. She had also trouble maintaining clear personal boundary and often became too close or too distant too quickly. Lastly, her sense of identity was also unstable. Systemic examination also revealed no significant abnormalities. The respiratory, gastrointestinal, and the central nervous system were within normal limits, except in the cardiovascular exam, the patient showed tachycardia. The mental status examination is basically the psychiatrist's version of the physical examination. It is defining status of the current state of the patient during evaluation. This approach is used to identify, diagnose, and monitor signs and symptoms of mental illness. Each part of the mental status examination is designed to look at different area of mental functions. Particularly in this patient, the MSc highlighted her emotional turmoil. She appeared tearful, anxious, and restless, though oriented to time, place, and person. She initiated eye contact, but frequently looked away with increased psychomotor activity with fidgeting and shifting posture. The patient was guarded at first, but the rapport was established gradually, with speech normal, with spontaneity. The subjective mood of the patient was, मुझे लगता है मैं खो गई हूँ, टूट गई हूँ, जैसे मेरी कोई अहमियत ही नहीं है, with the anxious effect, and there were active suicidal ideations present in her thought. All baseline investigations were done to evaluate the patient's medical status and readiness for psychotropic therapy, all of which were within normal limits. Overall, the findings were unremarkable, confirming that the patient was medically stable. So clinically, a pattern emerged. Repeated, deliberate self-harm following emotional triggers, particularly after relational disputes. She showed long-standing interpersonal instability, impulsivity, which aligned with features of borderline. She reported multiple romantic relationships that were intense and short-lived, often ending due to fear of abandonment. She also used substance, primarily alcohol and cannabis, impulsively, especially during her emotional lows. Notably, there were no prior psychiatric admissions or structured therapy despite the severity, and the family history revealed paternal alcohol use and frequent parental conflict contributing to her social vulnerability. So I'd like the audience to answer what possibilities. First, actually addressing the non-psychiatric differentials, especially the CNS tumors. There were no signs of raised ICP, seizures, persistent headaches, and focal neurological deficits. The metabolic causes can also be ruled out because there were no lab rearrangements and disorientation. In the CVS examination, there were chest pain, palpitations, exertional breathlessness, but there were no ECG changes indicative of a cardiac pathology. And in the endocrine causes, there was no history of weight loss, and abnormal thyroid function test, or random blood sugar. Now, coming to the psychiatric differential diagnosis. So first, like the member said, recurrent depressive disorder. In this particular patient, there were no symptoms of anhedonia or early morning awakening or psychomotor retardation. So that can be ruled out. With the coming to the second diagnosis, the bipolar, there were no history of previous hypersomnia, increased appetite, or increased energy levels. That can also be ruled out.
So I think a better term is unlikely. I don't like this can be ruled out. How can it be ruled out? There is still a possibility. Unlikely.
Right,
like
sir.
you did for the previous slide, no?
Right,
Unlikely
sir.
would be the right word.
Right, sir. Regarding the third, mental and behavioral disorder due to use of alcohol, there were episodes of binge drinking, and the last intake was also 7 days ago. There were no signs of current withdrawal symptoms, so that can be also unlikely. And the panic disorder, the panic-like symptoms were presented featuring inconsolable crying, palpitation, and they were often triggered by interpersonal stressors. We actually administered a hospital anxiety and depression scale called the HADS, a screening tool designated to detect the status of depression and anxiety in a hospital setting. The patient scored 18 out of 21 on the anxiety subscale, indicating severe anxiety. And based on this, the panic disorder remains in our differential. The last, borderline disorder, personality disorder, giving the affective instability, the recurrent deliberate self-harm, intense and interpersonal relationship. This diagnosis cannot also be excluded. And so, for further diagnostic clarity and structured personality assessment, I may now invite Ms. Yukta Mittal from Department of Psychology to further assess.
Thank you, Dr. Aryan, for inviting me on this stage. This case was referred to the Department of Clinical Psychology by the Department of Psychiatry for the better understanding of the patient's personality. At the time, the patient presented with the ideas of self-harm, feelings of loneliness and emptiness, as well as frequent crying spells. A detailed assessment of her personality was subsequently conducted under the guidance of Dr. Sneha Nathavat. So, firstly, International Personality Disorder examination was conducted on the patient. The assessment process involves a combination of semi-structured screening tool followed by a detailed interview with both the patient and the informant. Initially, a self-report questionnaire is administered only to the patient. Based on the positive indicators from the screening tool, a semi-structured interview is then conducted with both the patient and the informant. This interview evaluates the patient's enduring personality patterns and behavior and aids in diagnosing personality disorders in accordance with ICD-10 and DSM-5 criteria. So the rationale for conducting this assessment on the patient was to gain a clearer understanding of the patient's underlying personality in the light of her presenting concerns. She reported chronic interpersonal difficulties, marked emotional dependency, and episodes of self-harm. These problems suggested the need to explore the presence of any personality pathology that may be contributing to her current difficulties. So the summary of the test findings on the screening questionnaire, which was conducted only on the patient, paranoid, impulsive, borderline, and histrionic personalities came out to be prominent. In order to confirm a specific personality, interview was done with both the patient and the sister. During the clinical interview, she was reported to exhibit marked reactivity to criticism, often responding with aggression. She struggled with a fluctuating sense of self and unclear life goals. Her interpersonal relationships were intense but unstable, and she made excessive efforts to avoid real or perceived abandonment. Thus, the patient met the definitive criteria for the borderline personality disorder. To corroborate the findings, Rorschach ink blot test was also administered on the patient. This projective test is designed to assess the personality structure, emotional functioning, and emotional conflicts. During the assessment, the patient is shown a series of ambiguous ink blot cards and asked to freely describe what they see in them. The premise is that individuals project their inner thoughts, feelings, and conflicts onto the ambiguous stimuli, thereby revealing underlying aspects of their personality. For example, while many of us would see a bat or a butterfly in the first ink blot, the patient described it as a monster holding a weapon, a response that offers valuable insight into her internal world and psychological functioning. The rationale for conducting the assessment on the patient was to gain deeper insight into the patient's underlying psychological dynamics. It was particularly useful in uncovering her defense mechanisms or coping strategies. So the patient showed emotional vulnerability and had a tendency to become disorganized when under stress, indicating difficulty in managing emotions. Her thinking could be fragmented and she showed signs of impaired reality testing, which may affect her judgment. Emotional distress was frequently internalized and expressed through somatic symptoms like nausea that she was experiencing. She also experienced persistent feelings of sadness, anxiety, and emotional emptiness. A deep fear of abandonment led to excessive dependency in close relationships. Additionally, she tended to rely on fantasy as a defense mechanism to avoid distressing emotions, due to which her self-image remained unstable. The findings on the test were thus suggestive of borderline personality disorder. Now I would like to call Dr. Srishti on the stage for further discussion on the case.
Acute and transient psychotic disorder, it is more than 24 hours, but if it is lasting only for few hours, then they are called as quasi-psychotic episodes, and they are very common in borderline personality disorder. So they have quasi-psychotic episodes.
Border between what? Neurosis and psychosis,
yes,
right?
Sir. Yes.
Okay.
Thank you, Yukta, for the insightful information. Based on the history and personality assessment, the final diagnosis for this patient is panic disorder comorbid with borderline personality disorder. Now we start to discuss the management, which is broadly divided into pharmacological management and non-pharmacological management. Pharmacological management. Before initiating any medication, all relevant baseline investigations were conducted. All results were within normal limits. Following medications were started: tablet lithium carbonate, which is a mood stabilizer at the dose of 400 milligrams every 12 hours. An SSRI capsule fluoxetine 20 milligram once daily in the morning. Atypical antipsychotic tablet risperidone 0.5 milligram once daily at night. And a benzodiazepine tablet clonazepam 0.5 milligram on SOS basis. Non-pharmacological management. In addition to medications, we started brief counseling sessions during the inpatient stay to build rapport and begin emotional processing. Psychoeducation was provided to both the patient and her family. This focused on helping them understand the nature of her illness, the importance of emotional regulation, and most critically, the risks associated with self-harm and the need for treatment adherence. We also introduced principles from DBT, which is dialectical behavioral therapy. What is dialectical behavioral therapy? It is a structured talk-based therapy developed originally for individuals with borderline personality or BPD. It combines the principles of CBT, cognitive behavioral therapy, with concepts from mindfulness and acceptance-based strategies. DBT is especially beneficial for individuals who experience strong mood swings, struggle with self-harm, impulsivity, or emotional outbursts, or have unstable relationships. Why choose DBT in this patient? Let us begin by understanding the maladaptive emotional cycle our patient was stuck in before treatment. In this case, the cue could be anything: a fight with a friend, feeling rejected, or even academic pressure. This could lead to emotional dysregulation. To cope with the emotional overload, she would often escape by isolating herself, lashing out, and engaging in risky behaviors. The temporary relief gained throughout these actions, like self-harm or aggression, would reinforce the entire cycle. This reinforcement, while temporary relief feels rewarding, made the behavior more likely to occur in future. Without intervention, this cycle keeps looping, pushing her further into emotional chaos. Here we see how DBT starts to break that cycle. First, she was taught to recognize her triggers or cues, so she is not taken by surprise emotionally. Then she learned how to regulate stress, for example, through deep breathing, grounding, or distress tolerance techniques. Instead of escaping through harmful behavior, she practices healthy distractions like journaling or calling a safe person. This stops the reinforcement from taking hold and over time reduces the power of those emotional responses. In her early sessions, we focused on reducing the urge to escape, which started reducing the intensity and frequency of emotional outbursts. In the second phase, DBT builds more advanced tools like stimulus control and crisis survival skills. Our patient learned to problem solve when a cue arose. Instead of panicking or escaping, she engaged in active strategies. Over time, as these problems behaviors were no longer reinforced, meaning that they didn't bring her relief, the cycle started weakening. She stopped getting an emotional reward from her actions. With ongoing DBT skills, her emotional dysregulation began to settle. We noticed she was using coping skills independently, seeking help appropriately, and expressing emotions verbally, signs of real therapeutic progress. Clinical course of the patient. This slide outlines the timeline of patient's clinical progress from the day of admission to follow-up period over 2 months. The initial treatment plan combined pharmacological management with DBT. The patient was acutely distressed with panic symptoms and self-harm thoughts. Clonazepam was administered for acute symptom relief, started on a combination of lithium, fluoxetine, and risperidone to target mood stability, anxiety, and impulsivity. DBT sessions were initiated daily in ward to provide immediate emotional regulation support. By the end of first week, she reported marked improvement in panic symptoms and reduction in self-harm ideation. Patient was discharged on the same medications. Weekly DBT sessions were continued in outpatient follow-up. About day 3, on day 15, she started reporting improvement in panic attacks and self-harm. HAS shows approximately 15% improvement, and we went from 7-day follow-up to a 15-day follow-up. By 1 to 2 months, the patient started maintaining well, but also developed emotional dependence on the therapist, which we call transference. So a transference-based therapy was introduced to tackle it. At 3 months, the patient started experiencing an emotional breakdown after a fight, triggering the following symptoms: panic, disturbed sleep, substance use relapse. The patient presented to OPD following the breakdown. Management changes included restarting supportive therapy, increasing fluoxetine to 40 mg for mood and anxiety control. We started RTMS sessions 5 times per week, specifically targeting emotional dysregulation and impulsivity, and after 15 days, further adjustments were made. Endoxifen 8 mg was added in the morning to improve mood instability in resistant cases. Weekly DBT sessions were reinforced for tackling the behavioral coping strategies. At month 4 to 6, patient began to show response to this treatment. So transcranial magnetic stimulation. We have a transcranial magnetic stimulation. We have a device in our OPD which is applied on the head of the patient. So the cause of fight was with the partner and roommate more frequently because she was suspicious towards her partner and her roommate that they were having relations. So it led to a fight between them. Clinical course continued. This slide describes the final phase of the patient's recovery and journey, showing sustained improvement in transition into long-term maintenance. At 7 months, the patient had attained optimal improvement. RTMS sessions were gradually reduced to once every 15 days, reflecting clinical stability. The tapering was done cautiously to prevent rebound symptoms while encouraging autonomy. During 8 to 9 months, continued stability allowed us to reduce fluoxetine back to 20 mg, discontinue risperidone as symptoms of impulsivity and dysregulation had significantly reduced. Maintenance therapy sessions were given to support the patient through this transition. At 10 months, the patient remained stable on reduced medications and therapy and continued to attend regular follow-up sessions. Currently, the patient has had no self-harm or emergency visit in the past 2 months. She applies DBT skills independently and she is able to avoid emotional triggers. She is also free from harmful substance use and is functioning well in academics and part-time teaching. Now we start a review of literature with the prevalence of panic disorder. Sir, it is a temporary effect, but it builds upon along with the therapies. It helps the therapy to work better. When she's not experiencing anxiety, she's more likely to work on the DBT skills that we have taught her. And we are going to discuss how it acts in further slides as well.
How the TMS acts.
Yes. Globally, the lifetime prevalence is around 1.7%, meaning nearly 2 in 100 people will experience panic disorder at some point. In India, the lifetime prevalence is 0.5%, which is even lower than the lower income average. This could be due to cultural stigma, low help-seeking behavior, and underdiagnosis. According to DSM-5, in panic disorder, patient experiences recurrent sudden onset panic attacks for over a year, with symptoms like palpitations, nausea, trembling, and shortness of breath. These episodes can be often unprovoked, not tied to a specific external stressor. Between attacks, she experiences anticipatory anxiety and a fear of recurrence. It is a hallmark of panic disorder. Importantly, her panic symptoms are not tied to depressive or manic states or any other medical condition or substance use. Now moving on to the treatment, specifically pharmacotherapy for panic disorder, the first line treatments include primarily SSRIs and SNRIs due to their efficacy and favorable side effect profiles. The second line options are tricyclic antidepressants and MAO inhibitors, and benzodiazepines for acute symptom relief but with dependency risks. Third line agents are second generation antipsychotics and anticonvulsants. They are considered for refractory cases or specific comorbidities. Now we move on to borderline personality disorder. Global prevalence is approximately 1.6% in the general population, but estimates vary significantly from 0.5 to almost 6%. India's specifics are estimated lower at 0.3 to 1.2%, but it is based on limited research. Bipolar BPD is frequently underdiagnosed due to stigma, lack of awareness among clinicians, and its symptom overlap with other psychiatric conditions. Personality disorders, what are they? They are enduring patterns of thinking, feeling, and behaving that cause distress or dysfunction. They are divided into three clusters, cluster A, B, and C. Our diagnosis of borderline personality disorder is a part of cluster B. This slide highlights the clinical features of the BPD patients. Demonstration of frequent mood swings, intense emotional reactions. Relationships are highly unstable, often marked by arguments, fear of abandonment, and dramatic shifts in attachment. They show signs of identity disturbance, making statements like, "I don't even know who I am." Impulsivity is also evident both in self-harm behavior and in emotional outbursts during conflict. Another key feature is affective reactivity, with emotions shifting rapidly depending on the situation. Persistent feeling of emptiness, persistent feeling of emptiness, inappropriate and intense anger, or difficulty in controlling anger. And lastly, the stress-related paranoid ideations or dissociation. According to DSM-5, we have been given 9 criteria, out of which if 5 are present, we can diagnose the patient as borderline personality disorder. Now the treatment. The key to treatment here is a targeted symptom-driven approach. For effective instability and anger, SSRIs like fluoxetine and sertraline are often used. Impulsivity and aggression may respond to mood stabilizers like lithium or valproate. Cognitive perceptual symptoms like paranoid ideations or transient dissociative symptoms are addressed with low-dose atypical antipsychotics like aripiprazole, olanzapine, risperidone. Comorbid depression or anxiety is treated with SSRIs or SNRIs, similar to general guidelines for these conditions. For severe insomnia, short-term sedatives or benzodiazepines might be used cautiously. Now let us look at non-pharmacological neuromodulation strategies for managing emotional dysregulation and impulsivity, especially in treatment-resistant cases like this one. RTMS, repetitive transcranial magnetic stimulation, is a non-invasive method that uses magnetic pulses to modulate cortical excitability. In our patient, RTMS is used to target affective instability and impulsivity. Importantly, this service is offered by Department of Psychiatry, and RTMS has proven efficacy in a range of disorders including depression, OCD, and substance use disorders. TDCS, transcranial direct current stimulation, a low intensity current alters the cortical excitability, and it is used to target the areas involved in emotional dysregulation and aggression control. The third is deep brain stimulation, Though more invasive, it is reserved for severe treatment-resistant BPD, especially when there is comorbid depression. Review of literature. We want to discuss why we chose this case. As borderline personality disorder has a chronic, pervasive and fluctuating nature. As we saw in our patient, some patients often present in different departments with multiple comorbidities like depression, anxiety, substance use and eating disorder, all of which complicate management and are associated with poorer prognosis. Timely diagnosis in such case with myriad of symptoms becomes a challenge but is necessary for proper management. Unlike some disorders which may remit spontaneously, BPD follows a chronic and disabling course. Without appropriate intervention, even after treatment, emotional instability and interpersonal dysfunction can persist, with episode recurrence being common, leading to social and occupational impairment. There is also a risk of escalation from DSH, deliberate self-harm, to suicide. DSH in BPD is not always suicidal, but is a predictor of future suicide attempts. Chronic self-harm may desensitize individuals to pain and fear of death, increasing suicide risk. Hence, justifying the need for prompt and targeted intervention, early structured and specialized treatment like DBT, they can help in reducing harm behaviors, emotional regulation, and decrease hospitalization and suicide risk. Now we're going to differentiate between suicide and deliberate self-harm. This distinction is crucial because while deliberate self-harm may not initially be intended as suicide, if left unaddressed, it can escalate into suicidal behavior over time. Now moving on to the comparative features. Intent. Suicide typically involves a clear desire to die, where DSH can range from non-suicidal acts to gestures meant to communicate distress. Psychiatric associations. Suicide is commonly linked to depression, psychosis, and substance use, while DSH is more associated with borderline personality disorder, emotional dysregulation, and interpersonal crises. Repetition. Suicide is less often repeated due to its fatal nature. DSH is typically recurrent and a part of maladaptive coping cycle. Communication of intent. In suicide, intent is often hidden, but in DSH, it is sometimes communicated directly or indirectly as a way to seek support or express distress. Methods. Suicide often involves high lethality methods that are more violent or irreversible, like hanging or poisoning. DSH usually involves lower lethality methods, such as cutting or superficial overdoses. Sex. Suicide is more prevalent in males, while DSH is more common among females. Motivation. Suicide is driven by hopelessness, despair, and a wish to end life. DSH often means emotional dysregulation, a release or non-verbal communication of psychological pain. In our case, the patient aligns more with DSH with impulsivity, emotional triggers, and repeated non-lethal behavior. Take-home message. The major factor below are top 5 psychiatric illnesses reported in India with their prevalences. Psychiatric illnesses are common across all age groups and communities in India, but over 70% of these individuals receive no treatment. Why is that? The major factor is the underreporting of illnesses by patient and families due to social stigma, lack of awareness, misconceptions about mental health. Government has come up with various programs for reducing the stigma and spreading awareness, but we as doctors bear a critical responsibility as well. Another concern is that medical graduates receive minimal training in psychiatry, leading to under-recognition of symptoms, delayed referrals or mismanagement. It highlights the critical role of timely psychiatric referrals and the need for better integration of psychiatry in general healthcare, enhanced training in mental health for all medical professionals. With this, we extend a sincere gratitude to Mahatma Gandhi Hospital Management for providing us with this platform and continuous institutional support, respected faculties and CCR Review Committee. With special thanks to Dr. S.S. Jaiswal sir for invaluable guidance, encouragement and constructive feedback, Department of Psychology for their teamwork, collaboration and shared commitment, the patient and their family for their openness, trust and immense learning opportunity that they offered us, the Almighty for strength, clarity and grace throughout this journey. Thank you.